Good afternoon to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. J.S. Rajkumar. Sir is chairman and chief surgeon of Rigid Hospital. Sir is also founder of Lifeline Group Hospitals, Chennai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is never drugs render bariatric surgery obsolete. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you very much, Shreyan, for that neat, concise introduction. I want to start by telling every single person on the show that I would like to profoundly apologize because this has been fixed once, twice, and then only now it's actually coming to fruition. So let's jump into the topic because this concerns every one of us. Either the doctors will have patients who are either overweight or have diabetes or have blood pressure or have cholesterol or a varying combination of these that we call the metabolic syndrome, or the doctors themselves might have it. So here we go. Can newer weight loss drugs replace bariatric or metabolic surgery? I would like to start by defining bariatric versus metabolic surgery. Although where we cut and join stomach and intestine are nearly the same, in there's an overlap in these procedures. For bariatric, I do the operation because I want somebody to lose weight, full stop. For metabolic, I do the operation because I want them to lose their diabetes or their blood pressure or their cholesterol or combinations of these. So in the recent years, there has been a lot of understanding on how, when you operate upon bariatric patients with, say, a bypass, they would have only lost 4 or 5 kilograms, sometimes 7 or 10 within 3 weeks. But the sugars return to normal without medication. It was a great enigma initially, but we now know that this is because of hormonal changes in the blood, and that these hormones are directly because of certain insulin like secretions in the gut. And these internal insulin like secretions, this word phrase has been shortened to say incretins. So this for secretions, it's cret in insulin-like secretions. Internal is in so incretins. These incretins like GIP-1, GLP, oxymodulin, these are the ones which have made such a big difference to the treatment of these obese patients with metabolic disorders. So let's look at the two sides of the coin. On the one side, you have a surgery which, over the last 30, 40 years, has been reasonably well established as the standard of care in patients with a certain BMI, with a certain number of other complications and comorbidities. We'll talk about that in a minute. And on the other hand, you ask yourself, each metabolic or bariatric surgery is a huge drain on the purse of the patient or the purse of the system. Someone needs to pay. Also, you can at best do 4 or 5 or 6 metabolic or bariatric surgeries in one theater in a day. What about the millions of people outside who require tuning for their metabolic issues? And that's where the other contender, or the weight loss medications, come into play. We all know that obesity is a major public threat. If you look at India over the last 5 or 10 years, the obesity rates have been increasing at an alarming pace. We also know that This obesity doesn't come alone. It comes along with other metabolic, cardiovascular, skeletal comorbidities, joint issues. We also know that obesity increases the risk of cancer by 5 to 10, by a factor of 5 to 10 times. There is also, admittedly, a huge negative impact on the psychosocial health of every patient. We know too that obesity is definitely linked to increased mortality, and somehow physicians don't seem to understand that, or perhaps they don't understand that enough. I always exhort people. I say, look at the people who are walking by your beach in Chennai or in Indore by the bridge or in Delhi near India Gate, you will find that the early morning walkers, maybe 1 out of 50 or 1 out of 100 of them are morbidly obese. Whereas in the population, the obese and the morbidly obese are going up to 10 or 15%. So, why is it that you don't find these old obese men and women? The answer is that they don't really make it to that old age. By 70, the difference in survival between obese people, especially morbidly obese, and normal people, that difference becomes so marked that they don't survive to walk on the beach or to walk on the promenade. So, both weight loss drugs, either as tablets or injections, and metabolic or bariatric surgery, they're viable treatments for obesity. But their effectiveness and their appropriateness given that particular situation, these depend on various factors. So, when one chooses you as a physician, you need to choose how am I going to send a patient for surgery? When am I going to send a patient for drugs? You have to choose on these three major factors. One is the severity of the obesity. You cannot fire a pop gun at a charging African elephant. Severity of obesity is very important. Second, individual health conditions and comorbidities. Finally, there is something called personal preferences. You know how it is. You just have to have one bariatric patient or one metabolic surgery patient having a serious complication, and the whole system in that city will shut down. It's so sad that the press amplifies the negative effects of these surgeries. Look at these considerations. The severity of the obesity. If somebody has a greater amount of fat on them, then, as I said, it's like taking a children's popcorn and firing it at a huge African elephant. The severity of the obesity, the greater the severity, the more likely that they will benefit from surgery and less likely that they would benefit from drugs. The presence of pre existing health conditions and comorbidities is also significant. I'll tell you why. Supposing, for example, somebody has got cholesterol, sugar, blood pressure, reflux, and is significantly obese. You can use the drugs, and the drugs will reduce their weight a bit, but the drugs won't do anything, not much for their sugar and BP. They will do a little bit, not much for the cholesterol, and they will make the reflux worse. Almost all these drugs make gastroesophageal reflux significantly worse. So, in such a patient, I would personally put my vote in favor of surgery. Next, personal preferences. One has to look at people being surgically phobic. I don't blame them. I know that in India, especially in South India, people, the minute you say surgery, they go running. So, people who are surgically phobic will benefit more from the medical treatment. And people who want a quick and permanent solution will tend to choose surgery. Also, remember that this is one example where the medical costs run way beyond, unimaginably beyond surgical costs. Finally, it's good to have professional advice from many people, especially regarding fitness. Every now and then, we have a patient being worked up for bariatric surgery in our institute, where we cancel the surgery because the heart specialist says that the patient is not fit enough to undergo the proposed surgery. The next few slides are very important because they will outline the current available rock stars of weight loss drugs and how important they are. So the first is semaglutide, which is otherwise marketed as Ozempic or Rybelsus. The second is tirzepatide, which is marketed as Mounjaro or Zepbound. The third, which has been around for some time, is liraglutide. Again, more marketed as an anti-diabetic, which also has some weight loss benefits. The fourth, fifth, and sixth, which are drugs for morbidly obese patients, are the two of them have been given up almost because orlistat very partially effective and will not stand the test of a non-inferiority trial. Fentanyl, tremendous cardiac palpitation side effects, and again, doesn't seem to suppress the lateral hypothalamus sufficiently to prevent the patients from eating. The newest kid of the block is the bimagrumab, which is the monoclonal antibody to leptin, and we are still working on that. It's still work in progress. So if you look at semaglutide, it's a, as you saw earlier, it's otherwise known as Ozempic. It's something that blocks the GLP-1. GIP, it's an injection that's given for chronic weight management. At least one weight-related condition is required before the insurances can okay that. For example, weight plus BP, weight plus sugar, weight plus cholesterol. It's for use in addition to a reduced calorie diet and increased physical activity. If you just give that alone and expect the patient to miraculously knock off his metabolic syndrome, then you have another thing coming. So, semaglutide, once a week, 2.4 milligram, can cause fairly stiff GI symptoms, severe bloating of the upper abdomen, severe reflux, and discomfort and anorexia. Not only is it good to bring down the weight, but the great advantage of semaglutide is that it also works to bring down the blood sugars by increasing the peripheral impact of insulin at the level of the cells. Having said that, having said that, it has no significant impact on blood pressure, for example. There's some impact, but not significant. And definitely also not such a significant impact on cholesterol. So you can't quite take off all other drugs when somebody is on semaglutide. So it's indicated at a BMI of 27 kilograms or greater who have at least one weight related ailment, or simply in patients with BMI of 30. This is very similar to the guidelines for bariatric surgery, where if there is one weight related ailment or one other metabolic ailment, then the patient's cutoff for operating upon them comes down a little bit more. So instead of 35, BMI becomes 30 world over. And in the Asian data, 30 becomes 27.5. The adverse effects of the entire GIP inhibitor group are more or less the same: severe belching, eructation, abdominal distension, nausea, vomiting, constipation, headache, dizziness, fatigue, huge numbers. And in some patients with type 2 diabetics, it causes a blood picture that is similar to what used to be called the brittle diabetes of chronic pancreatitis. So the sugars will go up and down and cause fluctuations. Slightly higher blood sugars, as you all know, don't matter, but having the lower blood sugars could cause issues with nausea, sweating, palpitation, etc. So, quite a pretty package of side effects there, but one has to look at the lesser of evils. Come to the newer one, which works not only at the GIP level, but acts at the GIP as well as GLP-1 level, and it has a greater affinity for the gastric inhibitory peptide receptors than the previous counterpart, Ribelsis. So this is a 39 amino acid synthetic peptide with agonist activity with the GIP and GLP-1. So what does it do? More or less the same results as semaglutide, but I would say it's like semaglutide on steroids because it actually seems to reduce pancreatic beta cell stress. So it causes reduction in the pro-insulin to insulin ratios. It causes reductions of proinsulin to C peptide ratio. So what it does is that tirzepatide works on allowing the available insulin in the blood to be processed, to process, to work on the mRNA, better protein processing, and it may actually reflect less work for the pancreatic beta cells. So it increases the sensitivity of the cells to insulin, very similar to say metformin, the bigonides, and at the same time reduces the pancreatic beta cell stress. So by working on multiple levels, GLP-1, GIP, and on the pancreatic beta cell, it makes tremendous differences. Now, if you look at liraglutide, liraglutide also causes some improvement of blood sugars, but it works better on weight loss, produces a weight loss that is superior to the weight loss of orlistat. It's almost online with drugs like naltrexone and bupropion, which some of these are banned now because of a higher incidence of suicides because of CNS effects. But they were pretty good drugs, and liraglutide acts at that level. It's quite extensively used by diabetologists in type 2 diabetics with mild obesity, especially abdominal obesity. So primary problem, sugar, a little bit of obesity, liraglutide. Primary problem, obesity with a bit of sugar, then I would go for tersapatide or I would go for Ozempic. So the beauty of liraglutide is that it actually improves the cardiovascular risk factors, increases the ejection fraction of the left ventricle in some studies, improves the blood glucose levels, and as I said earlier, acts at the level of the receptors sitting on the cell wall and increases the sensitivity of those receptors to circulating insulin. By doing so, again, it reduces the strain on the pancreatic B cells and decreases the B cell, eases off the B cell function. Let's have a look at this slide. I'd like you all to spend a few minutes here. A few minutes here. So this is giving you an idea of GLP-1R agonism, which means by acting on GLP-1 receptors and potentiating the power of the GLP-1 on the cells directly and indirectly. How do these drugs affect the energy and glucose metabolism in peripheral organs as well as the brain? So, if you look at what GLP-1 agonism does at the level of the brain, it decreases food intake It actually decreases the palatability because people won't feel like they're enjoying their food when they're on GLP-1 agonists, and also decreases reward behavior. Reward behavior is binge eating. You feel bad about something, you bite into a bunch of five stars or chocolates or something. That kind of binge eating, reward behavior eating, is knocked out by GLP-1 agonist. If you came into the intestine, it actually decreases emptying of the stomach. So the stomach feels bloated and full, and the patient will not feel like eating again. Second, how does it maintain that fullness? It decreases gastric empty, right? Also decreases gastrointestinal motility. So you'll find the jejunum and the ileum will not be peristalsing frequently enough, and the patient will almost appear like he is in a post-operative paralytic ileus. That's the kind of feel that this brings about. Then from there, move to the liver. In the liver, it definitely decreases fatty liver. We're already looking at some studies at establishing how the liver is less fatty, less accumulation of fat inside the liver cells, thanks to this wonder drug. So it decreases steatosis of the liver, it kind of decreases the gluconeogenesis. One of the most difficult things for the liver in diabetes is that the liver gets to check out protein inside the liver and passes it to being broken down, for being broken down into amino acids. In other words, a very, very difficult situation in the liver of increased gluconeogenesis. And once glucose is discharged into the circulation, my friends, it gets converted into triglycerides. And all the triglycerides go into your body roughly 3 or 4 inches above the belt, between the belly button and the belt. That's where we all tend to accumulate um, the sugar, which gets converted into triglycerides, and the triglycerides are nothing but fat. So that's the important chemical equation regarding the changes inside the liver. Go on from there to the muscle. In the muscle, as you know, the muscle contains huge numbers of insulin receptors, and these drugs um, cause an increased sensitivity of the receptors to insulin. Finally, in the pancreas, there'll be an increased insulin uptake and secretion. Increased insulin synthesis will also happen. Glucagon secretion, it will kind of drop. There will be definitely a lower amount of apoptosis, and definitely the beta cell turnover will become larger. So all these changes which I mentioned in the liver, in the gluconeogenesis, the pancreas with the decreased apoptosis, which means the beta cells, the average lifespan of each beta cell will increase, muscle and insulin sensitivity, brain not having, not feeling hungry, and of course in the intestine, the decreased motility. All these things happen. I won't trouble you guys giving you all details about surgery, but just enough to say that you can either restrain somebody's stomach, control the size of their bites and their food. The first one, the second one, sleep gastrectomy does that. The first one, the gastric bypass, also does that. Or you could make sure that whatever they eat goes away from the system without being absorbed. And that's what was being done by the biliopancreatic diversion surgeons who kept the entire stomach to have only the size of a few bites. That's the gastric sleeve. Sometimes, if you look at the bypass type of procedures like the SAS-J, which is nothing but sleeve and augmented with a sleeve jejunostomy, or a biliopancreatic diversion with duodenal switch, or an endoscopic sleeve gastroplasty. To a large extent, it's a lesser procedure compared to these other procedures. Now, there are some people who say, Doctor, I don't want any surgery. Please take me just to the endoscopic room and back. And these people would benefit, some of them, with putting in a large balloon inside the stomach or even making the stomach smaller completely using the endoscopes. Both are possible, and I'll work on both of them for you. So when you look at all these are all surgeries that are kind of reasonably well proven over the last 30, 40 years. They all cause weight loss due to various mechanisms. You can see the first one on the left side is putting a band to keep the proximal part of the stomach small. This second one is what we call a vertical sleeve gastrectomy, where the stomach is stapled across longitudinally and it's got a much smaller size. Third one is my it's a Roux en Y gastric bypass, which means we cut the intestine and make it into a Y. I was just thinking whether we have the videos to show it, but I will not show you the videos and confuse you guys. You can please see here in this area, in this, how this part looks like a Y. Can you see? So the food that comes into the stomach will go down this path. This is called the Roux loop, where it will then be joined by the bile and pancreatic juice here, and it'll all come in and join here. This is the common channel. So if the patient had, say, for example, 300 centimeters of active small gut, we would probably have 150 here, or 120 to 150 here, and the remaining here. So the net result will be that this area of intestine is not available for digestion. So this part of the stomach, this part of the intestine, the new C loop, this whole thing, we just have to stitch this part and close it and open out the whole thing if we need to reverse it. It's so easy to reverse a bypass, almost impossible to reverse a sleeve. This is a very interesting operation where you hardly remove a small part of the stomach, but you allow the stomach to come straight into, practically into the anus. Certainly, I would be happy to, give company and take people through this some more. So this is a biliopancreatic diversion with the duodenal switch. In these last two, patients' malabsorption is huge. They go almost into negative balance from BMIs of plus 50 and plus 60. I have seen patients and I still follow them. They went up to BMI of 5 and 4, of 12 and 15, and so thin. 14 and 15 BMIs have been described after this. So one needs to take this with a pinch of salt too. But otherwise, fairly straightforward operations. The advantages of drugs, as you all know, is that this is non-surgical. No need for invasive procedures. You can modify the dosage. You can stop the treatment at any point of time if the patient has severe side effects, but to reverse a sleeve is almost impossible. You only need to convert it into a bypass. There is a lower initial cost upfront, but as you go along, these tend to become much more expensive than surgery. Less recovery time and no need for hospital stays, obviously. So, for these reasons, that it's non surgical, adjustable, has a lower initial cost, less recovery time. So, these are the advantages of surgeries, of non surgical weight loss techniques like drugs. So, here when you operate, a patient has theoretically 5%, 8%, 10%. This can become a big problem in surgical issues, and one needs to be constantly aware which is a side effect. So look at the effectiveness of drugs. You can't get a 40%, 30%, 35, 40%, which is often the average weight loss in surgery. You can't get that with drugs. They will only be moderately effective. There are side effects, as I mentioned: belching and eructations, foul smelling eructations, abdominal bloating, heartburn. All these are the side effects. Then long term use is always question. If you take it long term, one of the dangers is that the subsequent appetite that you get will become almost zilch. So you have to remember that you need to be a little healthy to eat and drink, etc. So never forget side effects. Long-term use, there's nobody who's taken it for 20 years or 25 years. We don't know. But 5, 10 years, we've got some good data, 5 years plus. Remember, you could have a rebound weight gain the minute they stop taking the drugs, which is a big problem. And varied research. You'll find one patient saying, Doc, I lost 10 or 12 kilograms, and yet another one saying, I've lost only 2. Please don't ever promise a patient that they will lose a certain amount of weight, because these are very unpredictable, completely unpredictable. Finally, there is no permanent cure for obesity related conditions. As long as you're taking the drugs, your sugar and weight will be under control, but that doesn't mean you're going to have a permanent solution. Now come to the surgeries. The advantage is that the weight loss is huge. It's there right in front of you to behold with your eyes. 20 to 35% of the body weight will just go. In some cases, we can tweak it to even 40 or 45%. Second, there's a definite improvement, not just improvement, but comorbidity. This comorbidity improvement is huge. For example, obstructive sleep apnea is the first comorbidity to go when you put them on bariatric surgery. It's one of the last to go when you put them on drugs. Type 2 diabetes, hypertension, and sleep apnea also run away like the flakes of snow before the morning sun. Whereas if you look at medicines, they'll take that much longer to come out and play. And not only that, you can have such a huge improvement with surgery. Long term results, very clearly available, my dear friends. We have 30, 40 years, 50 years of bariatric surgery results. They're right out there in any domain. Whereas we don't have those long term results for the drugs. The improved quality of life when a patient loses 30, 40, 50 kilograms, we see they're so happy to climb up the stairs. They're so happy to walk without puffing. It's a great game changer for them. To such an extent, it's unlikely to be useful for you to be involved in this care unless you look at it from the last point. It can be a life changing procedure. That's the sort of difference this can have. Such a huge. Other advantages of story. There's the blood sugar level much higher thanks to um, the huge impact push out of incretins. Lowered blood sugar, sleep apnea goes away almost immediately, BP comes down, the heart disease prevention is much more, cholesterol is lowered, the plaques are less, and one is pushed towards a more healthy form of lifestyle. So the entire lifestyle changes with bariatric surgery. This we cannot have this degree of change with drugs. Of course, the disadvantages of surgery: 1 out of 1,000 patients will, or 1 out of 100 will have a serious complication, some leak, and then every single paper will only be writing about that for a few days. So, undue resolution of some good suggestions will have to take it forward based on every individual case. Finally, the other disadvantages are irreversibility, like sleep. But if it's a band, you can remove. Balloon, you can remove. Bypass, you can reverse. Nutritional deficiencies are a huge problem in South Indian patients because they're not able to get in a difficult situation. They won't be able to get paints. They won't be in a position to get input from the newspapers. Overall, there is a singularly money-minded person. He is in cahoots with Venkat. Yeah. So basically, high upfront cost, lifestyle changes are required. You can't just say, I'll operate, I'll walk away. You have to make lifestyle changes, decrease the simple sugars, decrease the high calorie sweet drinks, etc. My worry is the nutritional deficiencies because India, a lot of India is vegetarian. And for vegetarians, when you do this operation, they're not able to hold the protein in their gut, and that can be a significant issue. So, let me quickly recap and compare. If you look at the effectiveness, how well do they hit surgery? Up to 35% weight loss, but as drugs, it's only 10% max. Safety, drugs, lower risk, but may have side effects. Whereas surgery, higher risk due to invasiveness, but much more cost effective in the long term. If you look at cost, drugs have got a lower initial cost, but and surgery has a higher initial cost. But for 10 or 20 years after that, you can just you can text at any point of time, be in touch with the doctor, keep on tuning your drugs. So this is a big advantage of drugs: tunability, mutability, whereas drugs tend to be a little in a bit of a hotspot. So one needs to look at every patient, how much they can afford, how scared they are, what side effects, what comorbidities, and then choose, which means that one will not completely knock off the other. I don't believe that weight loss surgery will completely knock off these drugs, and I certainly don't believe that these drugs will knock them off. They will both be mutually complementary. What do I mean by that? In as much as in some patients, we could choose only drugs, in some patients, only surgery, and in some patients, you can decrease the patient's risk profile by giving them the injections to bring the weight down, and then later we can operate. So, this is called saying using it as a bridge before surgery. Weight loss drugs can be an effective option for those with mild to moderate obesity or those who are not candidates for surgery. In those who have already been given, not so good news about their drugs, it's so good to see some people take it positively and say, okay, let me take the drugs, bring down my weight a little bit, and then undergo the surgery. So, preferred choice: metabolic and bariatric surgery in those with severe obesity because of its greater effectiveness, sustained weight loss, substantial weight loss, and they also improve other related health conditions. So that would be my concluding slide. And remember that if you have a healthy and a happy meal, you don't need anything at all. So anytime, if anybody's got any doubts or questions, I'm happy to take them now.
Thank you so
Hi,
much, sir.
Sriram.
Hi, sir. Thank you so much, sir, for the wonderful presentation. We do have some question if you like to take that up.
Absolutely.
So, sir, the first question is, can newer drugs replicate the long-term health benefits of bariatric surgery, such as improved diabetes management and cardiovascular health?
Ma'am, of the drugs available, I gave you five or six. The one that will at least approximate to the effectiveness of surgery are only two: tirzepatide and the Ozempic or Rybelsus. These are the only two that kind of come close to anywhere near the impact. Liraglutide is way inferior, or phentermine, all the other drugs way inferior, bupropion, all way inferior. The monoclonal antibody to leptin, bergrumimab, we're still working on it. All the rest are inferior to surgery in terms of effectiveness, in terms of how powerful that procedure is in bringing down the patient's sugars. So all these are far inferior, plainly speaking, in terms of effectiveness. If you look at bariatric surgery, 94.5% of patients will drop their sugar, BP, cholesterol, reflux problem if they undergo surgery. So it's pretty high, and by standard conventional uh, you know, criteria. So that's my answer to which drug comes close to. But even the best of drugs, you're looking at, say, something called EVW. Supposing my weight needs to be 80 and I'm 100, so I have an excess body weight of 20. If you look at Many bariatric operations bring down up to 90%, 80 to 90% of excess body weight will be knocked out. Whereas at very best, your daughter-in-law will probably have a weight reduction of 12-15%. So it's like a daughter and a daughter-in-law. Surgery is a daughter, it's a daughter-in-law, in as much as it's very much within the system already. The daughters-in-law are just coming in. These are the drugs. We treat our daughters and daughters-in-law alike, but after some time, we don't even know the daughters-in-law. These are new. We don't know the long-term complications. So very few drugs right now can equate the effectiveness of stark bariatric surgery.
So the next question is, what are the cost implication of using new weight loss drugs compared to undergoing bariatric surgery?
So very quickly, I'll tell you, 4 months of these drugs is equal to bariatric surgery cost. So if supposing somebody says, "No, doc, I was playing for the nationals. I was really slim. Then I got pregnant and I put on 25, 30 kg. I just want to bring down this 15, 20 kg and then I'll be on the track and I'll be back to normal." That's an ideal patient for a weight loss drug because you'll bring their weight down rapidly and she'll be working out and she'll come to that normal level and then continue. So the drug acts as a bridge here, not to surgery, but to get her back to her a lifestyle that's healthy and will support a sustained weight loss. So in that patient, I would certainly use drugs. 4 months of drugs cost is the cost of bariatric surgery. Please remember, I don't even have a single patient who stopped after 3 or 4 months. They all want to either keep taking the drugs, or if they stop 1 or 2 months, they see their waistline getting thicker, they go running to get the next injection.
Thank you, sir. There's one last question. Are there specific patient population or medical condition where new drugs may be more suitable than bariatric surgery?
Only fitness of patients. There is no because the word is effective in the question. There is no drug that is really more effective than primary bariatric surgery. What do I mean by primary bariatric surgery? First time, but somebody's had a sleeve or a bypass. They've put on weight. They've lost a lot of weight, and then they have what's called a weight regain. In that weight regain group, it seems that these injections are more effective than jumping into surgery. Patient has had one surgery, lost weight, and they've regained weight. In that situation, it's better for the patients if they take these injections rather than surgery. So, the only situation in which they are reasonably better than immediate surgery are in the patient who has a weight regain after a successful bariatric surgery.
Thank you so much, sir. We are done with the questions, sir. You have answered all our questions. So, sir, before concluding, any last message from your end?
Yes, this is an exciting space because if the monoclonal antibodies against leptin is the hormone that makes us hungry. So if you have monoclonal antibodies against leptin, it completely knocks off your appetite, and you'll be running around on an empty stomach, but your head is thinking that you're full. So very many path-breaking, epoch-changing discoveries are waiting to happen in this space. So watch this space.
Thank you so much, sir, once again for
Thank
joining us
you.
today.
Such a
Thank you, sir.
pleasure to see everybody. Good luck and dhanabad.
Bye, sir. Thank you.
Bye bye, Sriya. Thank you.